Greetings, everyone, and welcome to the 105th session of the Online Optom Learning Series, or OOLS. And today we have with us yet once again Dr. Daddi Fadel. She has been with us for one of the sessions on scleral lenses before. And as promised, I guess we did request her during the session to come back and talk to us again on scleral lenses. And as promised, she's back with us. I think those who know her, she doesn't need much of an introduction for the work she's doing. And for those who doesn't know her, she is a contact lens designer. She's a pioneer of modern lens design and a specialist in contact lenses for fitting irregular corneas, scleral lenses, lenses for myopia control, and orthokeratology. She speaks 5 languages. With that, I mean that she can lecture around the world with different languages, and that's what she's been doing these days by training optometrists around the world. She has studied optometry at the Institute of Science Optometry, ISSO, in Rome, and she completed a 4-year course within 3 years with honors. She started to lecture and publish from her initial optometry years in the school. She has 20 years of experience in optometry and specialty contact lenses. She also runs her optometric practice, which specializes in contact lenses in Italy, where she personally designs contact lenses and fits specially customized lenses for her patients. She is internationally recognized as a key opinion leader who has several peer-reviewed publications within the areas of specialty contact lenses, and she is also a speaker at various national as well as international conferences, seminars, and symposiums. Dr. Daddi Fadel with Dr. Melissa Barnett are authors of the Clinical Guide of Scleral Lens Success, which is a book, and very recently she has also authored a book on scleral lens complications, their recognition, etiology, and management. She is also a certified and approved advanced speaker to conduct NCLE approved courses. She is the first certified eye print practitioner outside the US and Canada, a fellow of the Scleral Lens Education Society, a fellow of the British Contact Lens Association, BCLA, and also she is a fellow of the American Academy of Optometry, FAAO. She is the founder and immediate past president of the Accademia Italiana Lens Scleralis, co-founder and president of the Australasia Academy. She is also in the Council of the International Society of Contact Lens Specialists, a member of the GPLI Advisory Board, a medical advisory board member of the International Keratoconus Academy. She is the program and education chair of the Summit of Specialty Lenses and of the Global Ophthalmic Women. She is also the board member of the International Forum for Scleral Lens Research and of the International Congress of Scleral Contacts. She also serves as a clinical advisor of myopia care in the International Relations Chair of the Scleral Lens Education Society, and she's also a member of International Association of Contact Lens Educators, which is the IACL. So with all that experience, today, Dr. Daddi Fadel is going to talk to us about scleral lens issues and complications, and this will focus more on the book, what she has recently written and published. And thank you very much once again for coming onto our platform and giving us your time. And let me just leave the screen time to you now, Dr. Daddi.
Thank you so much, Mr. Baradwala, for the invite and for this very nice introduction. And I would like to thank everyone for joining us. It's a pleasure for me to be lecturing on scleral lens issues and complications. Indeed, this was the theme of the book recently I published, and we will see some of these issues and complications. Why I wanted to treat this topic also in a book, fitting lenses and managing the issues and complications allowed me to learn a lot. And when problems occurred, I wanted to study them and learn from them. And now I want to share what I learned so far. I differentiate issues and complications because problems are different. Issues may not cause persistent alteration to the ocular surface, while issues related to scleral square are reversible. They may affect patient satisfaction and lead them to discontinue lens use. Complications, on the other side, are adverse events that cause persistent alteration to the ocular surface. Here I made a further classification based on the etiology. Issues and complications may be related to a non-optimal fitting relationship with the underlying sclera and to handling, care, and compliance. There are various issues and complications, and here we will see few of them. Corneal touch or bearing does not frequently occur when fitting scleral lenses because the scleral lens vaults over the cornea and limbus and touch only on the conjunctival tissue. Assessment with the slit lamp will localize thinner areas of clearance when observing an optic section, or a dark area using diffuse illumination with cobalt blue light. The evaluation with the OCT will show areas where clearance is absent. When it's located centrally, it's caused by a flat fit necessitating to be steepened. In this case, oval air bubbles will appear in the peripheral cornea, indicating indeed a flat fit. When it's peripheral touch, it may be caused by a peripheral ectasia. The first two figures are of the same eye. The first one shows a profile view of a very rare condition with a pellucid marginal degeneration centered superiorly. And here the OCT image shows a 20.60 millimeter scleral lens bearing on the apex, the center apex of the cornea of the cone. And the figure below shows a central and peripheral bearing. In this case, the scleral lens is fitted on a cornea with keratoconus. So in this case, it's necessary to increase clearance where the lens is touching or include a localized vault peripherally in the cornea, like in this case of Dr. Reef, where a scleral lens with localized area of increase in elevation is included in the corneal zone, in the peripheral corneal zone. This was designed for a patient with Salzmann nodular degeneration. Here, the optic section showing the clearance in the increased vaulting area, and the OCT image showing the localized vaulting on the elevated corneal area. Peripheral touch may also be caused by prolate lens fitted on an oblate cornea, so switching to an oblate scleral lens design will resolve this issue. Also, scleral lens of small diameter may touch the peripheral cornea, so in these cases, increasing scleral lens diameter or increasing only the vault diameter. The vault diameter is comprised the corneal and limbal diameters is necessary in these cases. Otherwise, we will have epithelial bullae, which will cause complication to the cornea and will compromise corneal health. With sealed scleral lenses, air bubbles in the liquid reservoir is the most common issue related to scleral lens fitting. So when they are small and floating, they may be acceptable because they may disappear after lens settlement and do not interfere with vision. Larger air bubbles should be managed because they may cause corneal delent formation and cause desiccation in the area where they appear. In these two cases, in the pictures here, the bubble should be managed. When fitting scleral lenses, air bubble may also show in lens periphery, in the scleral periphery, and we will see them how to manage these bubbles also. Air bubbles may be the result of handling issues. It's important to overfill the lens until the solution appears convex over the lens. It may also be caused by improper lens application technique. So educate patient to on proper application techniques. Here is a patient seated in a patient education workstation for lens application and removal. There are two mirrors. The flat mirrors helps the patient for fixation and keep leaning the chin to the chest. Both flat and vertical mirrors allow to the practitioners to monitor the patients when applying or removing the lens and to correct them if there are errors in lens handling. The eyelids should be opened wide and held tightly from the eyelash attachment because they may cause lens concentration, creating air bubbles formation when applying the lenses. Air bubbles may appear due to fitting issues. As stated before, oval bubbles in the peripheral cornea indicate a flat fit, so increasing central clearance by steepening, in this case, the transition zone or the back optic zone radius will resolve this issue. Air bubbles may appear due to excessive vault with small landing zones. So in this case, it's necessary to decrease lens sagittal height or to increase the landing zone weight. Air bubbles may also appear in scleral lens zone, as we stated before, and it may be due to flat periphery or lifted lens edge. So steepening lens periphery or lens edge is necessary. Also, significant toric or asymmetric sclera may cause the creation of these bubble in lens periphery. So reduce the lens diameter to be smaller to avoid the interaction with the toric or asymmetric sclera, or you may switch to a toric back surface periphery, more than 4 meridians, quadrant-specific design, or customized haptic. If the lens is already toric, you need to increase or decrease, respectively, the lens toricity. In this case, we are seeing some air bubbles, but these air bubbles is upon lens application, and they will resolve once the lens settles on the eye. So these air bubbles are small and are not to be managed because they are shown only upon application, and they will disappear once the lens settles. Also, irregular conjunctiva may cause air bubble formation. So in these cases, reduce scleral lens diameter if the irregularity is beyond the limbus. And this thing, we saw it in the last webinar. When the irregularity is near the limbus, we need to increase the lens diameter with slight compression, or you may introduce a notch or switch to customized scleral lens. Peripheral customized scleral lens. You have to avoid filling scleral lenses with aerosol saline and use a proper non-preserved saline. Switch to non-fenestrated lens if the air bubble, because when we fit fenestrated scleral lens, an air bubble is necessary. However, if the air bubble is still persisting and it covers the pupil area, switch to non-fenestrated scleral lens. Further recommendation may be the use of a more viscous solution for lens filling. Corneal staining does not occur frequently in scleral lens wear because, as we said before, the lens rests only on the conjunctiva. However, it's very important to assess corneal staining after lens removal to ensure corneal health. Corneal staining may be due to several factors, and its shape, which may be punctate, diffuse, coalescent, etc., will indicate of the etiology. So here in the image on the left, we have an optic section view showing an inadequate scleral lens vault over the keratoconus. In this image on the right is after lens removal, and a localized circular corneal staining showed in correspondence of the apex of the keratoconus where the lens was bearing. Here we have an image showing an air bubble formation due to a non-adequate lens application technique. After lens removal, we have a localized circular staining in the inferior area of the cornea due to the corneal desiccation where the air bubble was formed. Staining may also be due to an improper lens handling, like in this picture, and in these cases, the staining is generally vertical. Staining may be also caused by preservative toxicity, and in this case is diffuse. In these cases, it's important to verify debris, compliance, ensure that the patient rinses the scleral lens correctly before application. You can advise him to use a hydrogen peroxide solution for disinfection and storage, or add enzymatic clearance or progen to the care regimen. You may also choose non-preservative solution as non-buffer saline. If the staining is peripheral, like in this picture, this is due to the lens starting the landing on the cornea. So it's important, as we are seeing here, the black area indicating that the lens is landing, is touching the peripheral cornea. So in these cases, it's important to increase the vault diameter again, corneal and limbal zone diameter, or you have to increase the corneal vault periphery. Corneal bogging may occur after lens removal, appearing regular and looking like waterlogged. It's due to a prolonged immersion of the cornea in saline without nutrients. This condition is considered benign because it's transitory. Also, it may resolve after 2-3 months. The epithelium will adapt to the environment and the ocular surface will appear healthier and regular. Midday fogging refers to the presence of debris into the fluid reservoir, and it's an annoying issue for those who face scleral lenses. This phenomenon appears only with scleral lens wear. It may be transient, so lasting the first few months of wear as the eye adapts. There are 3 types of debris that may occur. Mucous debris appearing as small and white particles, diluted milk fogging associated with atopic diseases, and oil droplet debris. Atopic or ocular surface disease will cause a milky fluid reservoir, so it's important to manage atopy and ocular surface diseases before starting lens fitting. The presence of giant papillary conjunctivitis will more likely cause mucous debris, so reducing wearing time is indicated. You may also suggest the use of hydrogen peroxide solution or disinfection, or add an enzymatic cleaner or progen to the care regimen to avoid the deposition of to avoid the deposit on the anterior lens surface. In these figures, we are seeing in the upper one, we are seeing a large vault, which is causing debris influx. This may be managed by reducing the vault, like here we can see in this image now. So reduce limbal vault when there is an excessive clearance. The OCT picture showing debris formation with high limbal clearance, and reducing the limbal vault will allow to clear the fluid reservoir from debris. Reduce vault diameter if you notice that a large vault diameter, and check if the lens edge, because a scleral lens with a thick edge will alter the lacrimal secretion and will create debris formation. Oval limbus and significant toric or asymmetric sclera may be responsible for debris formation. So oval optic zone is indicated, the oval corneal zone and limbal zone are indicated in these cases, and managing toric sclera is also needed. Debris may also be due to the release of cells from the cornea, or because the solution are not compatible with the ocular surface. They may be also induced by the presence of preservative sensitivity. So in these cases, preservative-free solution for lens filling, cleaning, and storing is indicated. Switching to a fenestrated lens may be an option. The holes included in the lens will allow a constant tear renewal because they flushes out the debris from behind the lens. You may suggest your patient to wash their eye with a night bath in the morning before lens application. Scleral lenses may be applied, removed, and reapplied to clear the eye of the morning gunk, and you may also suggest them to use a more viscous solution for lens filling and or use a balanced electrolyte solution for lens filling. These clinically shown good result for patients experiencing debris in the fluid reservoir. You may also introduce topical mast cell stabilizer, and you have to avoid making breaks during the day to remove, clean, and refill the lenses, because this will worsen the debris formation. Instead, as we already said in the last webinar, you may hold the preservative-free saline to the lens edge and squirt the solution into the post-fluid reservoir. This is an alternative to removing the lens during the day. And in this video, fluorescein was used to show how this technique allows a complete renewal of the fluid reservoir from behind the lens. Conjunctival prolapse refers to the loss of the conjunctival tissue that transfer beneath the lens. It occurs in elderly patients, in those with inflammatory conditions, with atopy, with limbal cell deficiency, and in those who undergo several ocular surgeries. It may be considered benign if after lens removal conjunctival tissue retrocedes. It should be managed when it adheres to the peripheral cornea and induce neovascularization, as we are seeing here in this picture. So in the first figure, conjunctival prolapse is evident in the inferior quadrant from 3 to 9 o'clock. And here in the next figure, conjunctival prolapse is in the inferior and superior areas. Here we have conjunctival prolapse seen in OCT image. First image showing the prolapse in the nasal quadrant. In the image below, the prolapse in the inferior and superior areas, and more pronounced in the inferior area. Prolapse may be caused by several factors, including excessive central and limbal clearance, a large vault diameter. Oval limbus may cause conjunctival prolapse. So these two figures are of the same eye. Conjunctival prolapse has been recessed after decreasing limbal vault. It also may due to compression caused by the scleral lens on the conjunctival, so it's artificial. It's not a true conjunctival prolapse. When blanching is in the outer area, the landing zone is too steep, and this was seen in the last webinar. So flattening the peripheral corneal, limbal, and landing zone is necessary in these cases. When blanching is in the inner area, the corneal and limbal areas may be too steep or the landing zone too flat. An excessive pressure exercise when applying the scleral lens on the eye may induce prolapse, so patients in these cases should be educated on proper application techniques. In the photo here, we have an eye underwent keratoplasty fitted with the scleral lens. The prolapse is occurring in the nasal and inferior area. Limbal congestion is an engorgement of blood vessel in the limbal area. It could be circumlimbal or sectorial. In this figure, is circumlimbal congestion, and it's evident that it's caused by scleral lens compressing the conjunctiva in the inner area of the landing zone near the limbus. Here, the fluorescein pooling under the lens in periphery in the second image confirms that the landing zone is too flat. So steepening the landing zone and flattening maybe the corneal and limbal areas are indicated. Limbal congestion may be caused by significant toric or asymmetric sclera or irregular conjunctiva, or because the landing zone is too steep, as we already said. So it's necessary to flatten the peripheral corneal and limbal zone. It's important, not the the lens centrally, but the peripheral areas. It may also be caused by corneal or limbal areas that are too steep or landing zone too flat, needed to be steepened. It may be caused by pressure applied on the lens during application, so it's artificial. In these cases, it's necessary to educate the patient on proper lens applications. In these figures, we are seeing severe congestion with severe redness are showing also, and the blanching in the outer area are showing that these lenses are fitted too steep. Limbal congestion may be caused by toxic reaction or hypersensitivity to solutions. This figure shows severe congestion with severe limbal redness, and again, the blanching is in the outer area, showing it too steep. So generally, congestion is caused by steep lens. The limbus is where stem cells are located and are essential for corneal epithelium regeneration and proliferation. The limbal bearing may trigger epithelial failure, provoking severe complication. It's important to evaluate limbal clearance in the 5 gaze directions. We know that the eye is not static during the wearing time, so it's important to evaluate the fitting relationship with the underlying sclera in the different gaze directions. OCT may also be used to assess the limbal vault. The OCT image here is showing a limbal touch in the horizontal meridian. Here is an evaluation of the limbal clearance using the slit lamp with a diffuse illumination in cobalt blue light, and it was used a Ratten filter. The first image shows an inadequate limbal clearance, indicated an excessive limbal touch. The second one is of a moderate limbal touch, only horizontally. And the last one showing good limbal clearance without limbal touch. Limbal clearance may also be evaluated using the optic session in white light in different gaze direction again. Here we have inadequate limbal clearance in the image above, the slit lamp assessment showing a black area in the limbal zone, and the OCT showing the scleral lens bearing on the limbus. In these figures below, we are seeing an adequate limbal clearance with the slit lamp and with the OCT evaluating with both instruments. This is a case of harsh limbal bearing. There is an epithelium breakdown due to harsh limbal bearing and a punctuate staining in the limbal zone caused by this limbal bearing. Limbal touch may be caused by scleral lens of a small diameter, by lens decentration, by oval limbus, or by significant toric or asymmetric sclera. Tight fitting occurs when the lens is fitted too steep, like in this case in the image. The tightness of the lens may grow with prolonged wear. It's crucial to resolve this condition because it may cause various issues and complications to the ocular surface. Lens of small diameter, lens with thick edge, and steep lens may contribute to a tight fitting. Also, a scleral lens fitted too close to the ocular surface may cause tight fitting. So in these cases, a more looser fit may be indicated. A fenestration into the scleral lens may help reducing suction. So introducing a hole in the lens haptic as suggested also with Dr. Carrasquillo, not only in the limbal area, but holes may be also included in the scleral zone of the lens, may be beneficial to reduce lens suction. And when you include the hole in the scleral zone, you have to fit the lens a little bit looser to avoid conjunctival sticking in the holes. A swelled conjunctiva may cause tight fitting, so in these cases it's important to verify the initial fitting assessment. The fit will appear ideal, but a swelled conjunctiva will alter lens fitting, appearing tight. When inflammation and swelling resolve, blanching may disappear. A false tight fitting may also appear when applying the lens with excessive pressure. This case shows a tight-fitted lens causing conjunctival circumferential blanching and conjunctival prolapse. The image below is of the eye immediately after lens removal, showing an impression left by the skull lens, bulbar injection, and the prolapse, adding the prolapse of the conjunctiva, adding to the temporal inferior cornea. Scleral lenses may not be stable on the eye. Scleral lenses typically decenter temporally and because of later elevated nasal area compared to the temporal area, and inferiorly because of the gravitational and eyelid forces. The inferior temporal decentration will induce a thinning of the fluid reservoir in the superior nasal quadrant and the thickening of the fluid reservoir in the opposite quadrant, causing a prismatic effect. The higher the decentration, the greater is the prismatic effect, and the higher is the fluid reservoir, the higher will be the prismatic effect. In the first figure, we are seeing a mild decentration. In the second figure, we are seeing a significant decentration with a greater prismatic effect. Lens decentration may be due to several factors. In case of a flat scale lens, increase lens sagittal height. If the lens is bearing on the apex of the cornea, and in this case, you have to steepen the transition zone and the back optic zone radius. Steepening lens periphery may also be beneficial. If the corneal clearance is excessive, you have to decrease lens sagittal height by flattening these zones, the transition and the back optic zone radius. When there is an excessive limbal clearance, you have to reduce limbal vault. And also, it's important to assess the vault diameter. If it is large, you have to reduce it. Larger lenses may be indicated for better stability of the lens on the eye. You have also to assess scleral toricity, as we discussed in the previous webinar, and include toric or asymmetric periphery if the sclera is significantly toric. An oval limbus may also induce lens decentration. Fitting a spherical lens on a prominent oval limbus, the lens will land near the limbus in the horizontal meridian and far from the limbus in the vertical meridian, and this will lead this will create an excessive accumulation of the fluid reservoir in the inferior area, leading indeed to lens decentration. So the corneal and limbal zone should be designed based on HVID and VVID. And this will generate an elliptical scleral lens. Be aware that some limbus exhibit an oblique ovality, like in this case, and when you try to draw an ellipse on it, you have to turn in oblique to the ellipse to align with the oval limbal shape. Highly toric corneas may also induce lens decentration. The elevation map will indicate that there would be an excessive pooling of fluid in the inferior area, leading to lens decentration. In these cases, a toric corneal and limbal zones may be needed. Another annoying issue is residual astigmatism, which may be induced by lens decentration, by lens flexure, or internal astigmatism. So performing corneal topography over the lens is important to identify lens flexure. If there is lens flexure, toric periphery may be needed or a thicker lens. When residual astigmatism still persists or when it is lenticular, it's necessary to add a toricity to the anterior surface of the lens. Lipid and protein and creams can adhere to the scleral lens surfaces during daily wear. In case of tear, film quality and quantity issues, switch to a deposit resistant material. So in some cases, changing the material may be beneficial for reducing deposits on anterior surface. When removing the lens, rub and rinse the lens before storage to remove microbes, parasites, and debris. You may also suggest to use a hydrogen peroxide solution for disinfection and storage, or you may also suggest to add enzymatic cleaner or introduce Progent. You have to manage lid diseases and atopic diseases if necessary, and verify the use of creams and cosmetics the patients are using. You have to verify also the soap use. It's much better to prefer a non-moisturizing soap or those indicated for acne treatment. Use non-oil-based moisturizer to the eyelid margin and consider adding plasma treatment or Hydra bag. Different patients have a predisposition to experience poor lens wettability and are those with blepharitis, demodex, and dry eye. It's important to treat a pre-existing ocular disease before initiating lens application. Replace the lens when the plasma appears with irregularities, like in this case, and sometimes poor wettability is due to lab-related issue. In these cases, you need to clean with a lab strength cleaner if available, then clean and store with a solution of the care regimen. It's crucial to verify care regimen, plunger hygiene, hand soaps, cosmetics, and lotions. Hygiene and compliance are imperative, and we will see that later. Avoid hand washing soap containing lanolin, moisturizing or oil, and switch to soaps indicated for acne treatment. You may apply the scalants before applying makeup and remove before makeup removal. Avoid cosmetic inside the eyelid margins and add to the scalants a plasma treated or Hydra pack. Diet also is very important. You have to include assumption of omega-3 and avoid fats and fried foods. Okay, so before we go through the few slides on handling and care, let's have some polls. The first one here, we can start. Could you tell what is inducing this issue, this pattern? Is it excessive limbal clearance? Is it a good limbal clearance, or is it a low limbal clearance?
So majority of us think that it's because of the low limbal clearance. I think 53% of the attendees have voted for low limbal clearance. 32% say it probably is because of excessive limbal clearance, and about 15% say it's good limbal clearance.
Well, in this case, you are seeing, before I give the response, here you are seeing the landing zone starting here to land. So the lens is starting to land in this area. And here you are seeing an initial of a limbal congestion. The limbus is appearing a little bit edematous. So in this case, we have an excessive limbal clearance. The landing zone is, the lens is starting landing far the limbus. So the correct response is excessive limbal clearance. So in this case, let's see, if you have an excessive limbal clearance, what would you do to manage it?
So maximum majority of the attendees think that we should actually decrease the volt diameter or the limbal volt, 58% of them, followed by flattening the lens periphery, and then equal amount of people think we should probably increase the central volt or include peripheral toricity.
Okay, increasing central wall, maybe it will not resolve this. It will certainly not resolve this issue. Including the peripheral toricity is not the issue because you can include the toricity. However, the limbal, the excessive clearance here will still, the excessive vault will still persist. So in these cases, what you need to do is definitely reduce limbal clearance, limbal vault, and vault diameter. As you are seeing here, what I did is we are seeing the same eye fitted with the lens of the same diameter. What was done here, what was changed in this case is the lens vault diameter. So I made the lens start landing near the limbus, not far like in this case, and I decrease the vault. And here is the eye with a different geometry in the limbal area and the landing zone, because now the landing zone is much more larger because the lens is starting landing before, near the limbus. Okay, second case. What is creating this pattern? Excessive limbal clearance, good limbal clearance, or low limbal clearance?
Majority of the attendees think that it's low limbal clearance, 60%, and we have equal number of people thinking whether it's excessive or good between both of them.
Well, 60% of participants are right, because this pattern is of a reduced limbal peripheral cornea and limbal clearance, limbal vault. So in this case, the lens, this pattern showed immediately after lens application. So which will more probably induce epithelial bulli because of the mechanical friction on of the lens on the limbus. So in these cases, what would you do to optimize the fitting? Please pay attention, because here all the options are good except one. So one thing you will not have any benefit for to manage this issue. All of them are correct. Only one is not correct.
About 59-60% of the attendees think that you should probably not reduce the central clearance, but the other three, I think 20% think that increasing the lens diameter would not help. 14 and 7% would be limbal and vault diameter respectively.
Okay, so the correct response is reduce central clearance will not help in these cases. Increasing vault diameter, the vault diameter is the lens vaulting the cornea and the limbus. So this diameter, the vault diameter, includes corneal and limbal zone. Increasing the diameter will allow the lens to land farthest from the limbus and not start landing on the cornea. So increasing vault diameter will resolve this issue. Increasing the vault diameter in the vault in this area will also be beneficial. When you allow the lens to vault more on the limbus, we will have more fluorescein and more fluid in this area, and will resolve the issue. Increasing lens diameter may also be beneficial, because some lenses, the geometry of some lenses, the design of some lenses have the concept of, when increasing the diameter, also the corneal and limbal zone will increase. So increasing the lens diameter will resolve this issue. The only option that will not have any benefit on this issue is reduced central clearance. So these slides show, here we have the management. In this case, the vault diameter and the vault over the limbus have been changed. Okay, so these slides, I wanted to include these slides because they show how important to recognize earlier the issues in order to optimize the fitting, of course, but above all, to avoid and prevent complication to the ocular surface. Another key factor in preventing complication is patient education for correct hygiene and care. First of all, this period is very important to remind patients how important is hand washing and insist on this. The care solution of scale lens are similar to those of corneal lenses. The two major differences with corneal RGP lenses are lens rinsing and filling with filling solution, which should be performed using non-preserved saline. The important thing also is to avoid the use of tap water, even for case care. So since the filling solution will be in contact with the ocular tissues during full time of wear, the use of non-preserved solution is crucial to prevent toxic reactions. A sterile single-dose non-preservative solution, saline solution, is recommended to fill the scleral lens. Scleral lenses should be cleaned by rubbing for a minimum of 15 seconds, 15 seconds, and rinsing prior to overnight storage to remove microbes, parasite, lipids, and protein from the tear films, and also to remove cosmetics and creams that can adhere to the scleral lens during the daily wear. Removing the debris will increase the effectiveness of the disinfection process and helps to maintain lens surface treatments. Rinsing with a saline or multi-purpose solution will remove the cleaner and all residues from the lens surface, and you should definitely avoid the use of abrasive cleaners so as not to prematurely remove plasma or other surface treatments. Lenses should be stored overnight in a solution which provides disinfection. It has been reported that hydrogen peroxide neutralized with a metallic catalyst were most effective at preventing the formation of biofilm and minimizing contamination. A limitation of hydrogen peroxide storage system is the small basket included in the package. So it may cause shipping and breaking during application and removal of the lens from the case. An alternative is to use two basket cases, one for each lens. In addition, also a large basket case may be used, like this Pros disinfection cases. However, a platinum catalytic disc is not included in these larger basket cases. So it's necessary to detach a disc from the smaller case and place it in the bottom of the large case. Saline solution should not be used for lens storing because of the high risk of growth of microorganisms responsible for lens contamination and case contamination. Additional clearance once a week or every 15 days, depending on the ocular surface, may be used. Some solutions, such as Progent, allow the removal of protein by merely soaking a scale lens for 30 minutes. Here again, the container is designed for corneal lenses, but you may turn one or both supports to insert the scale lenses. Proper hygiene and care of the lens case also is essential to minimize or prevent the contamination. The case should be cleaned by rubbing, rinsing, and tissue wiping after each use. Tissue wipe the lens case after rinsing is essential because all solutions used for contact lens care are isotonic, containing a small number of dissolved salts. So allowing the case to air dry without tissue wiping it will lead to the evaporation of the liquid parts of the solution, while the salts, as we are seeing here in this picture, will remain attached to the surfaces. What will happen in the evening when the patient will put a new isotonic solution for lens storage? The solution will be mixed with the salt remaining on the surfaces, increasing the total amount of salts in the solution, transforming the new solution from isotonic to hypertonic. And we know that hypertonic solution may promote the survival of Staphylococcus aureus. Accessories also should be properly cleaned. They should be cleaned by rubbing, rinsing, and tissue wiping after each use. Cleaning the accessories is essential as microorganisms can transfer from the accessories to the contact lens, causing contamination and eye infections. The disinfection solution or extra strength cleaner with isopropyl alcohol combined with surfactant may be used for cleaning the accessories, or otherwise patients may use alcohol or alcohol wipes to clean the accessories. We know that patient may forget the recommendations during the educational session, so providing written recommendation is very helpful. You may include this recommendation also on your website because you may provide them with written, with brochure, but they can lose it. And we know how compliance is important for maintaining corneal health. Ocular surface health also. So put all the recommendation on your website. So patient, if they forget what they should do, they go to your website and they will refresh their memory. It's also very important to verify compliance at each follow-up visit by asking these simple questions and observing also the patient behavior when they remove the lens that they clean it, and correct them if you are seeing non-compliant habitude. So troubleshooting problems is fundamental in Scleral lens practice because most of the time the decision to use a Scleral lens represents a life-changing event for patients, and the issue of problems may result in eye surgery, depression, psychological problems, or emotional instability. On the other side, we have some practitioners who do remain intimidated by the preconceived notion, by the fitting process, and especially the potential onset of problems and their management. And as a consequence, clinicians will rarely, if not at all, prescribe Scleral lenses. So the increase of knowledge of Scleral lens fitting and management will allow the expansion of the use of these lenses, and the beneficiaries of knowledge development and spread of Scleral lenses are indeed patients. And different sources are now available treating various aspects of Scleral lenses. And as we said in the beginning of the session, just read the book discussing all the issues and complications. Those who that we just saw in this presentation, and much others that may issue with Scleral lens use. And thank you. I'm open for your question now.
Okay, so thank you so much, Dr. Daddi, for that very comprehensive talk covering, I think, the most, whatever complications you probably have covered are the most commonly seen ones. And I believe that those are the ones which we can manage them very, very efficiently without problems. So that's what we want to do. We want to have a practice where we fit patients and get minimum complications for healthy practice, right? Yeah.
Definitely. Healthy practice will generate healthy eyes
Healthy eye,
and
yeah.
happy patients.
Happy patient. That's right. That's absolutely true. I'm just gonna share that. So the first question here, Dr. Daddi, refers to the toricity. So if you have a toric cornea at the same time have a toric sclera, what would be the differences and how the balance should be made while fitting scleral lenses? Any tips on this particular aspect?
Yes, you have to make the toricity in the meridians in which the cornea is toric and the stabilization of the scleral lens depending on the lens stabilizing on the scleral toricity. These are calculations that may be made. I prepared an Excel for these calculations. So you have to compensate. First of all, what you need to see the sclera in which meridian is toric, the toricity of the sclera, and indicate the axis of the toricity. Then you have to compensate the corneal toricity based on the toricity of the sclera. So yeah, these are calculations that may be made by an Excel sheet that I prepared. I can share with you these formulas that you can do. It's a compensation of axis, not too difficult to do.
Okay, okay, fine. So, does that mean that we would probably have to design the lens rather than based on the trial lens set or something like that? Is that how we should go about doing the?
Okay, so you have two methods to design the lenses. You have the trial lens, and you can see the lens is not properly fitted, and change the fitting based on the parameter of the lens you are fitting. Or you can have an empirical fitting. If you have a technology that allows you to have an empirical fitting, it would be better because you will reduce the chair time. You will get faster to your final lens. If you have scleral topography or profiler, that would be great to understand in which meridian you have to design the lenses and immediately communicate these data and the topography to the manufacturer, and they will design the lenses that you are asking. There are two methods that you can use.
And I think you briefly discussed that in the previous session as well. I mean, we did talk about this superficially. So people, I think there was a question again on empirical fitting versus diagnostic fitting and all. So I think we leave that to that previous session if they can go and watch and get more details and more explanation. The next question here is, Dr. Daddi, about a case. So this patient, there was a patient which was seen by the attendee who has some kind of SPK, SPPK, and then they fitted a scleral lens for this patient, and they found there is a corneal touch at the 2-3 o'clock position. They tried to increase the sag and also the diameter, but there was still a touch. So anything you could imagine and give some ideas on what we should go about and how should we do?
So 2-3 o'clock, I imagine the center lens or a novel limbus. I don't know, it may be these two issues. However, increasing the diameter, so he fit for 14.50 millimeter lens. It's not sufficient to vault the cornea. It depends on the corneal diameter. How is the diameter of the cornea of this case? I think that 15.6 and also 16 millimeter are not enough. They should go larger. Going larger as a diameter doesn't signify that you are making the vault diameter larger. You have to enlarge to increase the vault diameter. So the diameter of the corneal and limbal zones, you have to increase these diameters. So you can suggest this to your manufacturer. Of how much, I don't know. It depends on the HVID. It depends on the eye you have. So if you have an HVID of 11.5 millimeters, you have to leave at least 1 millimeter per part to vault also the limbus. So at least the lens should start landing at 13.5 millimeters, and only 1 millimeter, 14.5 millimeter will signify identify that you have 0.5 millimeter per part for lens landing, which is not sufficient at all. 16 millimeter would be okay, but if the lens is starting landing at 13.5 millimeters, so it depends on lens design. You should verify the diameter of the corneal and limbal zone. Those should be enlarged.
Okay, okay. So I think, and probably this would be a good case to use a edge profiler, scleral profiler to see the scleral profile rather than this thing. But I understand that not all practices would have access to that. But I guess that would be something which would give us a more clue why that there is a touch always there.
Yes, so as I said before, this case may be also due to lens concentration. Lens concentration may be due to the presence of scleral toricity. You have to assess if the sclera is toric. I showed how to assess scleral toricity with only using the slit lamp. In the last webinar we did it together, so you can refer to that webinar to understand if the sclera is toric. If the sclera is toric, you have to include toricity, so the lens will center better, and this touch may be resolved.
That's right. Yeah. And just out of curiosity, would inducing or incorporating a prism base down to center the lens help these patients? Help this kind?
You don't know. You don't need to include the prism to center the lens. The prism are more likely introduced to stabilize a lens on a spherical sclera, because introducing a toricity on a toric sclera, the lens will be stable because it will align with scleral toricity. But in several cases, we have a spherical sclera, and we need to stabilize a scleral lens on that spherical sclera. So in these cases, a prism is used to stabilize the lens. But to center the lens, you don't need to use the prismatic. You have to include the toricity or make larger lenses. As I said in the presentation, larger lenses are more likely to have more stabilization on the eye.
That's right. Yeah, yeah, yeah. Okay, great. So thank you for that inputs. I guess the attendee would have gotten a brief idea of what to do, and you can let us know if you have any comments on that in the future. And this, I think, is regarding our last question or the last poll which we did. So the question is, will increasing the lens diameter not result in making the lens more flat? I guess this refers to the fourth poll, where we had the question of which one we should not do. So that probably relates to that particular question. So anything you would like to add on the changes in the diameter of the lens, and making sure of the fitting perspective?
So it depends on lens design. Some designs, when you increase the diameter, you compensate the internal geometry of the lens. So if you have to reduce the limbal clearance by increasing the lens diameter, that clearance will be increased. Because indeed, we saw this topic in the last webinar. Limbal clearance depends on the lens diameter. Small lenses have small clearance volt. Larger lenses, with larger lenses, we have more volt on the limbus. So I don't think that in this case, increasing lens diameter will decrease the volt over the limbus. It would more likely increase it, not decrease it.
That's right. Okay, okay. So that's again answers that particular this thing. And
But
let's yeah.
yeah, just to complete, you can make, however, as I started saying, responding to this question, you can indeed increase lens diameter by adjusting the internal geometry, the internal design. So if you want a large lens with a low limbal clearance, you can obtain it. Definitely, yes. What you cannot obtain is with a small lens, a large limbal vault. Here, there are problems.
That's right. That's right. And just for the knowledge perspective, what would be the largest lens diameter you would have fitted? Just to get an idea of, because we talk about large lens, large lens. What I think large lens, to my perspective, would be 16 to 17 millimeter.
19.5. Mine is 19.5. And I have a case in which I would go to 20 millimeters, and yeah, the sagittal height is quite high in this case. It's about 8,500 microns of sagittal height of the lens. So
Yeah.
it's very difficult to cut the lens. So I'm searching for a special lab to do that.
Okay.
So 19.5 millimeters, mine.
So the whole idea is, I guess, don't be afraid of going larger diameters. That's what people tend to get carried away, that, larger the lens, it will be difficult to achieve that landing, and it will be difficult to achieve the fitting. Patient might not be able to handle it well, insert it well. But I think that's not probably the cause in all the cases, right? It's the other way around. Larger lenses may sometimes be very beneficial to some patients.
I'm fan of larger lenses. I think that larger lenses cause less problem than smaller lenses. However, scleral lens diameter depends on several factors. It depends on the eye. If the HVID is small, so a large lens may be 16 millimeter for that eye. It depends on the HVID. It depends also on the palpebral aperture. With people having small aperture, you cannot fit a 19.5 millimeter. They would never open enough their eyelids to put the lenses. So you have to choose the correct lens for each patient. And if I have to choose, I would choose larger lenses.
Okay. So you would choose the largest possible for that eye, not in numerical,
Exactly.
right? Yeah, not in numerical. We can't say that 19 or 20 is the largest lens. For that particular eye, whatever larger we can go, we should actually go on that to minimize. Again, as you said, it minimizes complications as well. Right?
Exactly.
Yeah. Okay, I guess we have taken almost all questions. Thank you so much, Dr. Adi, for doing this session
Thank
again.
you.
And enlightening us with this thing. So thank you once again. Thank you once again, Dr. Daddi, for giving us this time from the team Online Optom Learning Series and all the attendees. Thank you so much.
Thank you all. Thank you for this opportunity, and thank you for everyone for your time and for being here. Thank you so much.
Most welcome. And we also want to let you all know that we do have a session tomorrow planned at the same time as of today. Again, it's a contact lens related session based on contact lens materials. So if you are interested to know more about contact lens materials, the recent developments, please tune in tomorrow. Join us same time as of today. Thank you so much, everyone, for attending. Take care, be safe, and I'll see you all again tomorrow. Bye-bye.
Bye.
Bye. Thank you, Dr. Adi. Bye.